So if this consultation goes through, as it happens, then we're investing in Norfolk Park, we're investing in St Mary's to make them bigger and stronger, build more beds in them to take the extra workload. We're investing in the community so that when those things are all in place, then we begin to change accident and emergency departments elsewhere. So well, it's quite clear, we cannot make changes elsewhere until those things are working.
Okay.
We predict it can take 4 years. If it takes 6 years, then we can take 6 years.
Okay, Greg first and then Black Hat.
Except that's not true. You see, the problem with what the doctors say, they say one thing that actually is not true. It's very often not true. They don't want to acknowledge it. You talk about A&E changes not happening. We were told last year that A&E night service at Central Middlesex was a temporary closure. Now it's a permanent closure. What a lot of health economists are saying is, when A&E closes at Central Middlesex, because there is no option in this proposal to save your local hospitals, A&E, the hospital itself will be vulnerable to closure in 10 years. We'll be sitting here fighting to save the hospital, because that's what happens as services like maternity was taken away and so on are taken away. Now the problem with that is, Dr. Kong said, she's very proud of the 1.5 years long difference in gap between being born in Harlesden, where you die at 69 years as a male. When you're born in Harlesden, your average life expectancy is 69. And the 1.5, yes, that's in your own document, Dr. Cobb. That's in your own document. And the 1.5 years she's saved through all the investment she's done between people in Kent. Now, actually, health economists have shown that the reduction in smoking, which is a fantastic NHS campaign, has actually reduced death by over 21% over the last 20 years. So the entire change is down to people stopping smoking and nothing to do with investment. The fact is, your own document tells us that you're born at 69 years, you live till 69 years in Harlesden, the lowest in the whole of northwest London. Of all the 2 million people, you die earliest if you're born in Harlesden. Don't know why you're supporting these proposals, sir. And then in Kensington and Chelsea, no hospital closures proposed, of course, you live to be 81. So there's actually a growing gap. Over 30 years of all the brilliant work that GPs like Dr. Cobb have done, there's a growing health gap. And what is the proposal in so-called shaping a healthier future? Take away the hospital so that more people in Harlesden will die earlier, and keep the hospitals in the wealthiest parts, like around Wembley. Thank you for mentioning Kenton. It's a point that hasn't been made. The richest people in Brent, such as they are, will have the best access to the hospital. There's a fact here from, a study done by Hammersmith and Fulham Council, who are totally opposed to shaping a healthier future, as are Ealing Council, as are Brent Council. If these proposals are so good for us, why are the 3 elected councils in this part of London totally opposed, organising marches? Why is that? Have we heard a reason why those councils, are they full of horrible people who don't understand health? No, they represent local people. Here's a fact I'd like you to comment on. Currently, the ratio of A&E to patients in London is 1 to 247,000 people. In the country, it is 1 to 259,000 people. It's actually a better ratio in London by 12,000 people. When you close all the A&Es, as Dr. Mark has already announced, the ratio in London will be, according to this independent study for Hammersmith and Fulham, 1 to 395,000 people. London will have the worst service, and Harlesden will have the worst of the worst service, and the health gap will widen, so that the people of Harlesden will pay the cost in their lives of what you are now proposing. That's why it's so important.
Okay, so Dr. Kong first, Vice this, and then you've got to go, and then you go.
Smoking cessation, you rightly say, it will improve people not to, well, if the rate of smoke, if we do not smoke, our health will be better. I agree with you. So again, due to the work with public health, if you look around your surgeries, we've been very actively involved with smoking cessation programs. And
That's what I said.
through the programs, which again is linked to health, clinics in the GP practices, in the community have been set up, and indeed in Brent, again public health data, I'll share with the gentleman there, smoking quitters in Brent, the rate of it has improved over the years. Again, I didn't make it up, it's public health statistics. Over the last 2009, 10, 11, the rate of quitters have got better in Brent. So again, what I'm saying is we are addressing health inequalities. Uptake it does, because indirectly it does improve the respiratory health of the patient.
Everybody does, everywhere.
Well, in smokers and people in Harlesden who tend to smoke at a higher rate as well. So again, through the campaign of breast screening, cervical screening and bowel screening, the uptake again have improved. So on that count, I do.
Thank you very much. Okay.
So could you answer my question? Just please, if you just answer the question. Why will the ratio of A&E...
That's what I think to Mark. That's Mark's question.
Nearly 50% higher in London as a result of your work.
You have me to answer that, I'll do that. The recommendation from the Royal College of Surgeons, from the Royal College of Physicians, from the College of Emergency Medicine, from the Royal College of Pediatricians, all of whom have written now supporting our changes, is that teams of specialists should provide care to a population of about 400 to 500,000. You will find across the country, hospitals are looking at how they merge, how they concentrate their services to provide this. So you're right, at the moment our hospitals are providing care of a much smaller population. All the evidence suggests they need to do it over a larger population, and although we may be leading this in our part of London, you'll find it's happening everywhere else as well. I'm sure you're aware of this, that other hospitals are going through similar changes. We're doing it to improve care, and that's what the evidence suggests we should be doing. So you won't find we're standing out from the rest of the country in the near future. The Chief Medical Officer expects that a third of the A&E departments in the country will be closing for the same reason.
Yes, Emma mentioned HIV/AIDS earlier, and what worries me is you've got people who want to save money. What will they go for? People with certain problems, HIV, Hep C, very vulnerable people. Have I got your assurance that services for these vulnerable people will not be cut?
Yes.
100%?
Yeah, at the moment they have ring-fenced funding for those services. It's commissioned not by the local GPs, but by the specialist commissioning groups who will be centred in the London regional office. And there's no plans at all to do that. But the government's, what they have is what they call an outcome commission framework, which absolutely stipulates that there can't be any funding, cutting those funding for those areas.
100% sure.
Yes, I'd like to ask you a question around the pace of change. At the early events that I went to, the consultation events earlier, and I've read the consultation document, I admit I haven't read the business case, I haven't seen it, I've been online, I've tried to follow things, I've got consultation overload, I have to admit, but nothing was said at those early meetings, and nothing is said in the main document about waiting until the out-of-hospital care is up and running and proved to be effective before you start implementing the hospital changes. Now, my question is, why can't you wait until it becomes clear where we no longer need the services? I mean, I'll take an example. I am not trying to say that everything should always stay the same within the NHS. When I had my first baby, I was in hospital for 10 days. The week after. When I had my second baby, I was in hospital for 48 hours. Very early discharge in those days. When my daughter had her children, she was out of hospital the morning after they were born. Absolutely. So clearly, how you configure maternity services will change as a result of that. Although I think it's ridiculous to have moved maternity from central Middlesex, where the birth rate is highest of anywhere in the locality, so that people have to travel all the way to look after the babies. So I'm saying to you, why can't you get those out-of-hospital services up and running and working, and then say, right, it's quite clear we no longer need this particular service because it's being provided effectively outside the hospitals. So now we can close it down and there won't be the fear, because people are incredibly concerned about losing an A&E. People in this area, the people most concerned are the ones that we see, because people who are very infirm and not out on the streets, but they're the parents of small children. They are really worried about the effects of having to go, you know, I have said this at a previous meeting, if you have to take a mini-cab to Northwood Park in the night, it will cost you £24 each way. Now, there are a hell of a lot of people living in the environs of Central Middlesex Hospital who do not have £48 sitting around that they can use in an emergency to get their sick child to hospital. And you give an example in one of the documents about somebody who takes a baby with a high temperature to A&E as a sort of, you know, she's a fussy mother, it was just teething. You don't need to go to A&E if your child is just teething. But if you're a mother, you don't know whether that high temperature is just teething. That's why you go. One of the essential functions of a doctor is, well, obviously diagnosis is experience that we rely on, and an essential function is reassurance. What if it had been meningitis? What if she thought, oh, it's just teething, I won't take her to the hospital? That baby could be dead by the morning. That's fine.
So the little child with a fever will go to your local hospital, be treated in the urgent care centre as it is now. There won't be a change.
And if it's meningitis?
Then they would arrange an urgent transfer to give an injection of penicillin, and then transfer to the major hospital by ambulance.
And that's what we want for people to follow.
And that would do. So we've been very clear throughout this. We will not make changes to hospitals until community services are up and working. We do have to plan ahead, therefore we will be making the investment in the extra space they will need at Northwood Park to manage with increased workload, because we're planning, because there's good evidence that what we're putting in place is working and working elsewhere.
We don't know that it's Central Middlesex where they won't need it anymore.
So we know that Central Middlesex provides care to a small population and won't be sustainable for the long term. There's good evidence for that, and so that's why we're modelling that care. One of my first jobs when I became medical director for the patch, across London, we suddenly found that our maternal mortality, the chance of a lady dying in childbirth or shortly afterwards, was twice what it was elsewhere in the country.
10 cases at Northwood Park. I think you've chosen a very poor example.
No, I chose a really good example because I then got called in to help lead investigations of why that was happening. So I spent time looking through the notes, talking to all the clinicians who were caring for these ladies who then died, or not caring for ladies who then died. And what became apparent was the reason it was happening is because people were left to deteriorate, being looked at by junior doctors and junior midwives, not noticing people were becoming ill until the condition got worse and worse until fatality happened. Now, what's very clear is there's a very strong correlation between that happening and senior doctors being on place to see it. So where ladies were looked after by consultants, by senior midwives, round the clock, they were getting better care. And so we are very clear as clinicians that we want to have maternity units where there's a consultant on site 24 hours a day. Now there just aren't enough obstetricians to do that on as many sites as we have at the moment. Therefore we need fewer sites, so make sure there's always a consultant on site to stop that happening. I'm glad to say that having done those reviews, having increased the number of obstetricians, the birth rate in maternal mortality is getting better because we've started making that investment. But that's the direction that we need to continue.
Well, I'm just going to agree with you that we must be absolutely clear that the services that we're putting in place outside of hospital are running and working and are effective before we make substantial changes to hospital-based services. Now, look after, as I've already said, 4 CCGs, 4 clinical commissioning groups in outer north west of London, and certainly in Brent we have made great strides in relation to putting in place out-of-hospital alternatives to hospital care. So 2 really great examples are the START service, which has been in place now for quite a while and is already supporting people to stay fit and healthy in the community and avoiding the need for people to go into hospital when they really shouldn't be there. And the other example is the urgent care centre, which is now seeing about 85% of people who need urgent care are now able to get that urgent care from the urgent care centre, and that will stay. If these proposals go through, the urgent care centre will be providing 24/7 care to local people, and the vast majority of people who go along to the centre for urgent care now are treated within the urgent care centre and will continue to be so treated.
Okay,
communicate this more effectively. That's what people in the community don't understand this.
Absolutely. So 85% of people need urgent care, go on to the urgent care centre, are treated and are very satisfied by what they get. Those people who can't be treated in the urgent care centre would, in the vast majority of cases, be transferred in an ambulance, they dial 999, or if they do turn up as a walking wounded, they'll be transferred urgently across the
try and publicise it, because most people don't spend their life thinking about health matters.
No, I agree. If those sorts of messages are not getting
Very quick. I couldn't remember the answer. One group that we kind of ignore are people with mental health problems who I understand use A&E. So what is going to happen for them?
So the things they use A&E for are normally managed in the urgent care centre. And so they'll continue to have care locally in the urgent care centre.
Can I just check?